And next we'll have Dr. Michelle Lofwall, Associate Professor in the Departments of Behavioral Sciences and Psychiatry in the Bell Alcohol and Addictions Endowed Chair at the University of Kentucky, speak to us about buprenorphine.
Great. I don't have any slides. My conflicts, I don't have any current conflicts, but in the last year and a half, I received research funding from Braeburn for CAM 2038 and was a consultant for them on their trials. And then several years before that, I was involved in the probufene research trials. So my talk is in large part I wanted to share with you is about diversion, which relates to access and stigma. And I would say that the stigma, we're sometimes being nice, and we should call it discrimination, because that's really what it feels like. Can you hear me? Okay, sorry. So I think very clearly there's no question that buprenorphine is effective in decreasing mortality. I think the two really wonderful new studies that show real-world data and the real-world practice outside of clinical trials is the Larochelle study, and then also Robert Schwartz's study in Baltimore City with access to care upon demand. Those are the studies that I go to when I'm trying to fight diversion, stigma, and discrimination. And then the studies that we've shown in Appalachia that the use of diverted buprenorphine is in large part because people can't get access to treatment, and I think Tracy Green's group just showed this also in the Northeast. The same thing happens there. So just so you know, diversion by define as misappropriation of medication to whom it is not is prescribed gets to somebody else, and it can occur with or without an exchange of money and can have altruistic and non-altruistic underlying motivations. Misuse is different from diversion. Misuse is taking a medication by other than how it's supposed to be taken. So snorting it or injecting it when it's supposed to be taken sublingually or orally would be examples of misuse. And these are behaviors that are happening and make it payers sometimes not willing to offer the treatment, make it difficult. So when you ask about waivers, why don't we have more waivers? A lot of times it's because of the barriers, which also include prior authorization. So we can be treating someone in the hospital for their underlying a complication of an opioid use disorder like endocarditis. They could have had no prior authorization for that admission, gotten a heart valve replacement, lots of days in the ICU or CICU, have initiated treatment with buprenorphine in the hospital without having to get a prior authorization, but now at the time of discharge, if we're lucky to find a waivered doc that's a hospitalist, we have to get a prior authorization for that prescription, which just seems bizarre, right? You've spent all this money, we're treating the underlying disorder. Within that context, also, there aren't really access to addiction providers in the hospital. So that might be something to really think about how that can be incentivized, because the barriers to outpatient care, getting more waivers there with money, not inadequate reimbursement, the same thing happens in the hospital. You say you want to start an addiction medicine service. They say, okay, let's look at the finances. You know, medicine's a business. And there are very few places that have really addiction medicine services. So how can we encourage that? The hospitals are certainly benefiting from the expensive procedures. A lot of budgets at the hospitals are made based on transplants, on ICU stays, of which in large part are patients who have underlying addiction. And how good could this be also for not only for opiate use disorder, but for alcohol use disorder, where these are patients also. When you're treating and doing the waiver, it's teaching you not only about opiate use disorder, but it's teaching you how to take an addiction treatment history. That applies to alcohol too. So there's lots of wins to medical schools and to hospital associations, perhaps to JACO, because certainly don't we want all that money that you just spent on that heart valve repair? Sometimes we've had 2 or 3 heart valve repairs in a patient. The mortality is really high if this group relapses, right? I mean, it's a win. It just makes sense about cost effectiveness. So what else can I tell you? The DEA is a real barrier for docs, and the language is a barrier too. We've got to start saying the word remission a lot. Every time you say the word recovery, please say the word remission with it. Remission and recovery. When I'm trying to get an internist or a family practice doc that really hasn't been doing any addiction, and they keep hearing the word recovery, and then they ask, what does that mean? It means, oh, having a purpose in life and getting a job. And it's like, oh my God, the patients all have felonies. It's on me as the doctor to get them a job? And I said, no, 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 your job, this is a disease, this is a disorder. In the DSM-5, you're going to check this checklist, and your goal is remission. We want recovery for all of our patients. Don't you want it for your cancer patient? Don't you want it for your diabetes patient to have a sense of purpose and things? So the language has to change so that it's more synonymous with the rest of medical illnesses if we really want to make this attractive to primary care docs. I would just say there's some really interesting data. Laura Fanucchi is an internist or hospitalist that I think all the clinicians know there's in-hospital drug use. Like, people bring in illicit drugs, but it's like never documented. And so some of her studies are actually documenting this. So I think it makes to help the argument move forward. Thank you.
Thank you for your insights and brevity, Michelle. That was wonderful.